All right. Hi guys, how are you all doing? Can you hear my voice clearly? I can see the chat window. Okay, I think there is a lag over here. So I'm going to be responding to your comments a bit later because there is probably just a 10-15 second lag. तो ये मत सोचना यार कि हम लोग मैसेज लिख रहे हैं ये सर को सुनाई नहीं दे रहा क्या दिखाई नहीं दे रहा तो lag है. All right. So I'm just waiting for you to just say will sir deliver the lecture. अरे वाह, great. Okay guys. So मेरा नाम है डॉक्टर जगदीश चतुर्वेदी एंड यस मैं वही आदमी हूँ जिसके बारे में आप सोच रहे हैं कि जो हूँ बट टुडे आई एम गोइंग टू बी टीचिंग यू सम ENT एंड आई वांट टू आस्क यू वन थिंग वेरी ओपनली गाइस. सी इसको दो तरीके से कर सकते हैं. आई कैन डू इट आइदर एज अ वेरी सीरियस टीचर प्रोफेसर. विकास इज सेइंग माय वॉइस इज echoing. Voice is echoing because my thoughts are echoing with you. I'm actually using a mic also, so it's okay. A little bit of echo is there. I don't know what to do. Nanda is saying can't understand Hindi. Okay, we'll keep it in English, but thoda idhar udhar we'll use Hindi also so that everybody is catered to it. Okay, let me see. I don't know what we can do about the echo. Let me see. Okay, is this making my sound better? I'm kind of reduced the echo and sound now. All right. Let me know if it is better. Starting trouble is there everywhere. Yeah. Yes. Apple also launched very cool echo sound is still there. Yeah, I have done everything from here, so I don't know how to change it. But these are the only filters. There's noise gate and suppression level. Okay, I have suppressed it as much as possible. Voice okay. All right, great. Okay, guys. So we can do this two ways. See, guys, you must agree that experience is needed to do well in something, right? And tell me one thing, guys. If somebody does really well in an exam and only gives it once, that is really not much experience. But whereas someone like me who has given exams so many times, so many times, in different ways, it's very hard to not get that experience in exams. So I have learned a lot of things and a lot of tips and a lot of patterns that they ask in exams from personal experience. क्योंकि बहुत सालों तक एग्जाम दिए हैं, अच्छा लगता है एग्जाम देना. It's nice. I like people testing me. And with that, I've learned some patterns. And one of the most important patterns is that past year question marks, our history always haunts us. Our past always haunts us. All our histories should be incognito for that reason. But unfortunately here, everybody knows about our history and our past exam questions are very important because somewhere or the other they are asked. Now I'll tell you one thing, guys. I've been a student for many years because I loved studying, so some subjects I did for many years. Then I became expert in those. But I also have been sitting on exam boards and giving questions for examinations, and that time I understood the thought process of what examiners want to know when they make and set these kind of papers. And it's very commonsensical, okay? The commonsensical sound is that, hey, why is saying Newton's sound is in 1D? Use smart board please. Okay guys, before I continue, see, smart board use करने से हम लोग सब smart नहीं हो जाएंगे. We're not going to become smart by using smart board. I am only going to point out some images to you and answer some questions. We don't need a smart board. I'm not drawing flowcharts or any big theories over here. Okay, for that you need a smart board. Here a dumb PPT is good enough. All right, so we'll do that. Say mukkamma. See, all these other requests, guys, please, I will do it at the end. When you put in a comment section, I will respond. Okay, but here let's focus on the class, and I'll make it fun. Okay, I'll make it fun with your permission. But first I want to say is that I know what examiners want to know. See, examiners nowadays with the NEET and now next coming in, basically want to know that any student who give these exams should be able to meet two criteria. One is they should be able to treat most common conditions, and they must be able to treat emergencies, because emergencies is one thing where you cannot be googling. You have to really know it. So emergencies have taken a really strong position in these exams and common questions. But 20% they will ask here and there because it's also a competitive exam, right? So kaun upar niche jayega, so for that reason, right? So that's why what I'm going to do today is going to cover some past questions But at the end, I have a surprise for you guys. So stay till the end. I'm going to give you something that is going to make your ENT preparations for your exams super easy. And I'm going to release or reveal a very, very small secret on how ENT question papers are being set. And that will really help you to prepare for it. But I'll do these question answers. Okay, so are you all ready, guys? Okay, forget about the echo and all of that. Now, whatever technical glitches are there, we got to live with it, right? That's how life is. It's never perfect. So now we have the technical glitch. We don't have smart board, and we are now, you and I are all over here, and we are ready to learn ENT today doing past questions. Now, do you want me to do it in a serious way, or do you want me to do it in a slightly fun and offbeat way? I want to hear from you. Shall we keep it serious, or shall we keep it thoda sa masti karke? Remember, there is a lag, so when I'm saying I'm not able to see your answers immediately. Okay. Fun way. Okay, all of you saying fun way. Fun way, and all right, 1 second. Go ahead, mic do rakho. One second, guys. The tech team is reaching out to me. All right. Let me see. There's no request. Fun. Okay. All of you are basically asking for the fun way. Okay. So I'm going to do this. See, this is a question answers, and one fun way to do question answers is to do it like Kaun Banega Crorepati. And I am not going to imitate Mr. Amitabh Bachchan. I am going to imitate a very bad imitator of Amitabh Bachchan, whom I would like to imitate, because he came one day for a mimicry show and he did such bad, mimicry. And mujhe laga ki I should imitate him, and we will do it in his style, and in the middle I will come in my own avatar and I'll keep teaching you some things. But the question and answers we can do in the Amitabh Bachchan style. We'll keep most of it in Hindi, Keshav, don't worry. Sorry, most of it in English, don't worry. Okay, we'll mix it up, and we'll mix and match. Okay, while the tech team is fixing the sound, are you guys ready for doing this in Kaun Banega Crorepati? Alright, we cannot be Croropatis over here because we're all going to become doctors, so it is the opposite. So I'm going to say Kaun Banega Neetapati. Oh, sorry, Neetapati to Mukesh Ambani hai, mere प्रिय मित्र हैं. So मित्र को इंग्लिश में इन्वेस्टर बोलते हैं. Sorry, अमित शाह. Sorry. Let us move and call this कौन बनेगा नीतपति. Neetpati. Are you guys ready to play Neetpati? We are going to do this. All right. So guys, I'm going to ask you the first question, and we're going to play कौन बनेगा नीतपति from your past question papers. And here is the first question on your screen, and I want to know who's answering it. Which of the following is not a feature of tuberculous otitis media? Which of the following? TB का symptom नहीं है. TB of the ear. So there is earache, कान में दर्द, multiple perforation यानी छलनी, pale granulation, खून भरी मांग, and foul smelling ear discharge. So guys, what is your answer? Which is not a feature of tuberculosis otitis media? A lot of people are answering as A. Okay. Let's see. Keshav is also answering A. Sun. Everybody is answering A. कौन है दो? Oh, everybody. Okay. Tanveer Singh has answered D. बहुत बढ़िया. एक दो ऐसे होने चाहिए. Very nice. सच बताओ जब कुछ कर एको रखना है ना. Okay. All right, guys. सही जवाब है ear ache, because हमारे पास ear ache, कान में दर्द. And guys, here is the explanation. देखो, tuberculosis. India is the capital of tuberculosis. यहाँ पर TB मिल सकती है, लेकिन PB नहीं मिल सकती. I'm talking about me, Big B. Anyway, guys, jokes apart. This is, tuberculosis is extremely, common in India. And one of the common things about tuberculosis, you see, if you look at this particular, the way the questions are being asked over here, right? Generally, tuberculosis is a very chronic condition, so pain usually is not there. But technically, I would say this is a little incorrect question, because pain is subjective. Relationship में भी दर्द होता है, and अगर कोई बात ना करे तो दर्द होता है, कोई बात करे तो दर्द होता है. So pain is subjective, guys. So we can't really say that pain cannot be there. Definitely, some people with tuberculosis otitis media do develop chronic mild pain, but it is not a prominent symptom. But if you look at the other three options over here, they are very, very prominent features of tuberculosis. Multiple perforations, everything is multiple in tuberculosis. Even the lymph nodes are all, flat, multiple matted lymph nodes. Granulation is a feature because tuberculosis is a very granulomatous disease. And of course, foul smelling ear discharge because tuberculosis, the bacteria, all the byproducts. All of that, cause problems. So that's why if you can see here in this image, if you see in this image over here, this is the normal eardrum, alright, this is the normal eardrum, and in the background a lot of people are doing the tech work. Okay, you see the normal eardrum, and these over here in tuberculosis, you can see that here there is multiple perforations. You can see granulations, which is this red color granular tissue, thickened, eardrum, and discharge. Scanty discharge is also going to, confuse you with the unsafe CSOM, which also has scanty, foul-smelling ear discharge. But here in tuberculosis, also there is scanty discharge because of the nature of the disease. All right. So guys, so tuberculosis always generally in every exam, one question on tuberculosis, usually comes. All right, guys. So let's get ready for a second question. And for the second question is आपके computer screens पर. Which of these is true about keratosis obturans? इनमें से कौन से keratosis obturans के बारे में सही है? So one is failure of migration of desquamated epithelium along posterior meatal wall. Wow, reading this only, we all have keratosis obturans in our heart. पत्थर दिल. Widening of meatus and facial palsy might be seen. Associated bronchiectasis. Bronchiectasis बोलते ही आवाज मस्त हो जाती है. Bronchiectasis and sinusitis and all of the above, guys. What is the answer? Some of you are saying A, and A is failure of migration of desquamated epithelium. Some of you are saying B. Some are saying lol. Some of you are saying D. Very nice. Very disturbing, very well distributed thing. Guys, tech team is working on the background for sound. Yeah, see, if you want to be a doctor, you got to get used to inconveniences. Yeah, हर चीज मस्त नहीं होती मेडिसिन में. Okay, all right. मतलब खूब disturb hot है. All right. Mimicry मत करो सब में. Okay, so something में करेंगे. All right. So guys, what is the correct answer over here? The correct answer over here is all of the above. See, keratosis obturans is basically means skin growth. It's keratin, and that becomes very, very stony hard. Obturans means blockage. So basically, it is stony hard blockage of the ear canal. And when the stony hard blockage is there of the ear canal, it completely is very, very hard. It's not. This is a wax that does not dissolve very easily. पिघलता नहीं है, सख्त है. It doesn't really dissolve very easy. It's very, very hard, and it causes a lot of symptoms because of that. And because of these desquamated epithelium along the posterior meatal wall, it grows there, and that's why it causes all of this blockage. And a widening of the meatus and facial nerve palsy can be seen, and I'll explain to you how. See, when you see this particular thing over here, see, keratosis obturans usually seen in young patients, aged between the age of 5 to 20, and when the keratosis obturans is there, the posterior wall, which is posterior superior part supplied by the facial nerve, sometimes a lot of the compression of it can press on the facial nerve and can cause facial palsy. And it has also been found that incidentally there is a lot of correlation between bronchiectasis and sinusitis. 77% of adolescent cases where this is seen as a combination, as kind of it's not called a named syndrome of any form, but it is seen together. And that's why facial palsy, because of the erosion of the vital intratemporal structures that are there, that can be seen. Alright, so that's why keratosis obturans will have all of these things. It is because of the failure of migration of desquamated epithelium. It causes widening because it's stone hard. It starts compressing the sides. It compresses the facial nerve, and it is seen as an association with bronchiectasis and sinusitis. It is a postgraduate level question, but it has been asked sometimes. 20% of the questions will be in such a way which will be technically a little more strong, and that's why this question is being asked. All right. So we are focusing on the study. That's the way it should be. Guys, I cannot change the logo now because this logo is already sent in the presentation, and it is there on the slide, but I am reading out the choices for you so you will not miss anything. Okay guys, so guys, this is the second question, keratosis operans. This is what it looks like. This is the Sakt Londa of waxes. Very, very hard. It has to be surgically removed, literally broken into small, small pieces. Sometimes you can use some sort of peroxide and glycerine and those kind of drops, and that also can sometimes help in reducing this particular thing. All right. Now, next question, guys. Identify the maneuver depicted in this image below. Okay, there are 4 maneuvers that are being shown: Epley's maneuver, Trotter's method, McGovern's technique, and Valsalva maneuver. Can you tell me which is this particular answer? Feeling like college lecture. Can we use helpline? C. Okay, C, B, A. Okay, so here there is a lot of confusion here. Everybody is answering multiple things. Okay, so there is Epley's, Trotter's, McGovern's, and Valsalva maneuver. And this whole procedure that is shown, where there is somebody bleeding from the nose and you are pinching the nose and bending forwards, this is called as a Trotter's method. This is the Trotter's method, guys. This guy called Trotter who identified this. And basically, see, it's not like how we see in the movies, no? In the movies, when we see that the moment there is, bleeding, you ऊपर देखते हैं and you try to stop the bleeding क्योंकि यार खून precious है, खून चला नहीं जाना चाहिए, right? So, but blood, when you swallow your blood inside and it goes inside the stomach, the blood, the hemetin in the blood reacts with the acid in the stomach and causes a product called acid hemetin. It causes acid hemetin. And this acid hemetin is very, very corrosive, and it can cause severe vomiting and cause more bleeding because of the rush of blood, into this particular this thing. Rush of blood onto the face, and it can cause more bleeding. And that's why acid hemetin is caused, and that's why when you want to stop the bleeding, you bend down forward, pinch the nose for 10 minutes, and spit out all the blood. And that is called Trotter's method. What are the other options? Epley's maneuver is basically for BPPV, benign proximal positional vertigo. When inside our utricle, there are certain stones called utricoliths, and when those utricoliths slip into the semicircular canal, so this saccule is there, and then the macule is there, and then you have your 3 semicircular canals. This utricolith enters inside, irritates the semicircular canal, and patient gets up with vertigo. And when the patient gets up with severe vertigo, what happens is that when patient is lying down and tossing and turning in the bed, vertigo is BPPV. This maneuver is a complex head movement to put all of those utricoliths back inside the utricle. That is the Epley's maneuver. McGovern's technique is done for babies who have aspiration of blood is a question. Okay. McGovern is for corneal atresia. That is correct. Sayantan Basu's answered correctly. See, what happens is that when you have corneal atresia, babies are obligatory mouth breathers. Obligatory nose breathers. They can only breathe from their nose. They don't know how to breathe from their mouths. And that's why, they take this bottle feeding nipple and make a hole in it and put it inside the mouth. And when they do that, when they put the bottle feeding thing inside the mouth remains open, baby is able to breathe. This is temporary till we are able to do the surgery and create the airway, okay? So McGovern's technique. And before we move on to the next question, guys, there's some questions over here. It's a serious class going on, Malik is asking. Right? If you say fun, we'll do fun. If you say serious, we'll do serious. But if half of you say fun, half of you say serious, then what is the fun here? Okay. But guys, so this is the thing. I have been told that we can take a break for 5 minutes to sort the technical issues because you seem to be very disturbed by it. So we can take a small break for 5 minutes while the tech team fixes this echo issue and the other issue that is there. I don't think this logo can be changed because already the slide has come, and then we'll do it. So let me just quickly check and give me a second. All right. Okay, is the sound better now? Are you able to hear the sound better? Okay, yes, a break, sir. Break 50 minutes. अभी तो शुरू किया है. It's okay now. All right. All right, guys. So let us continue. Okay, so you see in these old movies, जैसे दिखाते हैं ना, one of the reasons why all of this bleeding control, is little faulty is because of the Bollywood influence. You know, there's somebody वो finger पे चोट लग जाता है, and then either the hero or heroine take the finger and suck the blood and all of that. Right, and then after that, after some time, she'll have vomiting, and then one old lady in the house will say, "Khushkhabri, khushkhabri." It's acid emitting, yeah. It's acid emitting, and it's all that vomiting that is causing because of drinking blood. You're not supposed to drink blood. Okay, Trotter's method. Epley's is for BPPV. McGovern's technique is for this, and Valsalva maneuver. You know, when the eustachian tube gets blocked, we blow in air into the eustachian tube to pop the ears open, and that is the Valsalva maneuver that is there. Okay, so let us continue, guys. Some people are getting echo and some people are not getting echo, but we will continue so that you can hear what's happening. Okay, guys, what is Pott's puffy tumor? Pott's puffy tumor. Gamla, फूला हुआ. Subperiosteal abscess of frontal bone, subperiosteal abscess of ethmoid bone, mucocele of frontal bone or mucocele of ethmoid bone. ये आपको एंटीना नहीं है, एंटीना घुमाने के लिए. Somebody saying एंटीना घुमाओ. Sepphoris, which is the answer? Hey, अंकित पांडे एम्बलिक मैन्यूवर वो कहीं और पता नहीं क्या कर रहा है. ठीक है. All right, everybody here is very clear that it is a subperiosteal abscess of the frontal bone and mucocele of the frontal bone. What is the difference between these two, guys? They look very similar. Okay, everyone over here seems to know एक को lock कर दिया जाए. Subperiosteal abscess of the frontal bone. Guys, this is an important question because Pott's puffy tumor is by Percival Pott. It has nothing to do with tuberculosis. Normally, when we think Pott, we think that it's something to do with tuberculosis. And many times on Clever Examiner will put one tuberculosis option there, and I will go Potts, and you will go into that. But that's not true. This is the explanation for it, guys. See, a Pott's puffy tumor is basically what happens is when there is frontal sinusitis, there is a connection between the frontal sinus and the periosteum and the bone, because they're very close friends. बोलते हैं दोस्ती को रिश्ते में बदल दिया जाए, and उस दोस्ती के रिश्ते को बदलने के लिए there are this diploic veins which don't have any valves. So there is infection that and blood flow that easily spreads from the frontal sinus towards the frontal bone. And because of that, because of the marrows and the herbaceous system that receive all of this blood, the infection goes and starts infecting the bone. And the area around the bone develops abscess that is called subperiosteal abscess as a complication of frontal sinusitis, and permanent bindi lag jata hai forehead pe काफी time तक के लिए. And basically then you have to excise and drain out the abscess and treat the frontal sinusitis. Okay, so as you can see, this is a CT scan. It's a sagittal view, it's a side view. Here you can see that around the bone, this white lining, all of this is subperiosteal abscess or osteomyelitis and inflammation. This over here is the frontal sinus over here. How is this different from a mucocele? Okay, how is this different from a mucocele? A mucocele is basically a cystic kind of filled with mucus inside the paranasal sinus. It is there inside the frontal sinus. Here what you see is an MRI. This is not a CT scan. Because CT scan you see bones better. Okay, here you are seeing soft tissue, and you can see that this mucus filled secretion, and even in the surgical table you can see mucus is coming out from these collections, and this does not have any bony involvement. Okay, that is the thing. Bony involvement is not there. In subperiosteal abscess, bony involvement. 1 second, yeah, let me just write to them. Why there is no request coming? बार बार लिख रहा है request accept. There is no request coming. And mucocele is going to be soft, of course, and bony swelling is going to be hard. But yes, as you can see over here, that this mucocele is pushing the bony wall forwards also. So you can still see a forehead swelling, and that's why they will not ask you, tell us what the finding is. They are asking very specifically Pott's puffy tumor and subperiosteal abscess, because if they show you the clinical image, they will look quite similar. But when you do the examination and you do the CT scan and the MRI, you're going to find them to be difficult. All right. Okay. So the voice has become perfect now. Very nice. I don't know what has happened. दो ऑडियो इनपुट है, एक को बंद कर दो, but there is no request coming. Okay, guys, we'll continue. If the voice is clear, the sound is very nice now, we will continue. All right, guys. Now, following lesion in the vocal cord, what image does this depict? This fula fula suja suja on the vocal cord. What is this? Is it rhinchic edema? It is malignancy, trichomalacia, or laryngeal papilloma? What is this? Vocal cord lesion that you can see. Rhinchic edema, malignancy, trichomalacia, or laryngeal papilloma. Apoptosis is written laryngeal papilloma, D, okay? Anybody else has any other answer other than D? Oh, D. Okay, Sayat and Basu is always there to chip in by saying Rhinchic edema. Very nice. Most of you are saying it is D. And the Sahi jawab is laryngeal papilloma. Guys, okay, now here is the analysis for this particular question. Okay, so what you're seeing on the vocal cords is this whole papillary, this small edematous, tissue. So this is what it actually looks like. Laryngeal papillomatosis is caused by HPV infections. You see this human papilloma virus infection, and sometimes they may ask you which is the most frequent types in 6 and 11, but there is 18, 31, all of these jinka roll number hai wo alag alag aate hain, but 6 and 11 are the ones that are most successful because they have cracked most of the exams. So you have laryngeal papillomatosis there. Up over here is, you see, this is the normal vocal cord. So this is the difference that you are seeing over here. The only difference is, you get this side, this is anterior here, and this is anterior here, depending upon the camera that is being used. So this is the vocal cord in abduction, this is a vocal cord in adduction, and this is laryngeal papillomatosis. Now, what are the other options? You saw Rhinchic edema over there. Rhinchic edema is actually a very common condition. Rhinchic edema is basically, there is a non-muscular part of the vocal cord beneath it. Okay, there's a bit of a small fatty layer, and that is called as a Rhinchic space. And this Rhinchic space sometimes will get edematous because of some chronic inflammation, and that causes Rhinchic edema. And this is most commonly seen in people who smoke a lot. Tobacco history will be there. So if the examiner is asking any question that says, there is some swollen vocal cord, but there's history of smoking, you may get confused between cancer, and you may get confused within Rhinchic edema. Rhinchic edema, you will see a smooth swelling. You will not see very, very broken or tissue. Like I'll show you, this one over here is laryngeal cancer, and you can say the cancer is very, very irregular. Squamous cell cancer, carcinoma, second most common, tumor after in the respiratory tract following lung cancer. Okay, so here you can see it looks very, very rugged, very, very scary, whereas Rhinchic edema is extremely smooth, and it is a globular swelling, whereas papillomatosis will appear like this. And what is the fourth option that was there? Trichomalacia. Okay, so trichomalacia is basically the tracheal wall is flimsy. That's what it means. The tracheal wall is not having its strength. So trichomalacia is basically a very, very flimsy trachea. It collapses, and when it collapses, it basically, what happens is there is narrowing of the trachea that causes stridor. Now, very important thing to remember is, as you can see, in inspiration, when air is going into the lungs, the trachea expands, and in expiration, the trachea slightly contracts. So in inspiration, there is no stridor in trichomalacia, but in expiration, the trachea collapses when the air is being pushed out. So that's why, remember guys, this is also another question that is commonly asked. Expiratory stridor is usually in tracheal lesions and bronchial lesions, all right? Because during expiration, when all that air is going in, the stridor is only there during that time. While coming in, the trachea expands, because the trachea expands along with the musculature. So that's why it doesn't happen. But when you are pushing out air, it collapses because those muscles of inspiration relax. And that's why expiratory stridor is a very important thing that is asked. सर थोड़ा स्पीड बढ़ाइए प्लीज. अबे ENT में ज्यादा क्वेश्चन नहीं पूछते जी. मेरा 10 मिनट में खत्म हो जाएगा पूरा प्रेजेंटेशन, फिर क्या करोगे? थोड़ा सा तो हमको उसमें टाइम ले लेके आपको समझाएंगे. बिकॉज सी गाइज, इट्स नॉट ओनली व्हाट इज द राइट आंसर दैट इज इंपॉर्टेंट ओवर हियर. Each option can be a question, all right? Each of the sub options can be a question. So next time, some of the other questions can also be asked. So don't worry about the speed. I will close it within the speculated time, and you will not lose time for your preparation for other things. But each of these sub questions are also important, and that's why you should know that. Okay, guys. Now Arey, aa gaya. Inspiratory stridor is found in which kind of lesion? And I think I've already answered this. This is supraglottic, subglottic, bronchus, or tracheal. Supraglottic, subglottic, bronchial, or tracheal. Inspiratory stridor is found in which kind of lesion? Sir, tuberculosis कैसा दिखता है? Tuberculosis will always look slightly bloody and granular, generally everywhere that it presents. It appears little clumped, small tissue, not very aggressive, and granulation is always pointing towards tuberculosis. And in India, anybody has any granulation tissue, tuberculosis is always a question. Okay, A is basically the answer. Supraglottis is inspiratory stridor. All right, very nice. Most of you are answering that correctly. Guys, here's the thing. Okay, now logic is this. When the airflow is the most, the sound is the most. So when you are inspiring, most of this air that's entering from your nose and your mouth, when you're going, even sometimes when you breathe normally, you're getting that sound, right? That's because the supraglottic area, which is the area above the glottis. Glottis ke upar ka area is all the pharynx and the area behind the epiglottis. All of these areas, when they're there, when the air goes through it and there's something blocking it, you will have inspiratory stridor. And when it is below the glottis, subglottic area, especially below into the trachea and bronchi, it is expiratory stridor. But when it is there inside this particular area, which is just around the glottis, slightly subglottic, cervical trachea and glottis, you will have biphasic stridor, because very narrow and air speed is equivalent almost. No other muscles are playing a role, and you will have a biphasic stridor. Yes, stridor की वजह से आपका costume rehearsal छूट गया था. Atharva Batwe is reminding me this post-traumatic stress disorder that I had because of stridor. And stridor is very important, guys. So vocal cord, stridor, nerve supplies, these are the questions that are asked, and you can see in the past questions. Why do babies wheeze sometimes? Babies wheeze sometimes because they have a very narrow airway, and they're often filled with secretions, and they're not able to drain out those secretions very well because the mucociliary clearances are also not very well developed, and they also develop edema very quickly, and that's why babies sometimes wheeze. And when they have these respiratory infections and all of that, you can hear the wheeze much more clearly. It's just like when you take a small straw, you take a big bamboo, depends on what you drink your alcohol with. Anyway, that will decide kiska wheeze kahan par hoga. Okay guys, so now saccule develops from which of the following structures? Sacculus anterior, sacculus posterior, pars superior, pars inferior. I know this is not an easy question, but saccule kahan se develop hota hai? This is a bit of a tricky question because you don't know what saccule they are referring to. Saccule basically means a sac. It could be a saccule anywhere in the body. But what do you think is the answer? Sacculus anterior, sacculus posterior, pars superior, pars inferior. In ENT, where does saccule come? D, pars inferior. Okay. Where are these stridors seen? Okay, while you're answering D, Ankit is asking, where are these stridors? Stridors are typically seen in patients post-tracheal intubation. So when patient is admitted into the ICU, they put an endotracheal tube and they inflate a cuff, and that cuff is usually there in the second and third rings of the trachea, and that cuff is a high volume low pressure cuff, but still it constantly applies a lot of pressure on the wall for 4 days, 5 days, 6 days, and that causes a fibrotic healing process that after extubation within 24-48 hours, the trachea, when the fibrotic healing happens, it stenoses. Sometimes it can stenose much later also. But one of the biggest causes of tracheal stenosis or stridor is long-term intubation. So when you get a question where there is a history of intubation and somebody was intubated for many days, usually more than 3 to 6 days, there is somewhere leaning towards a tracheal stenosis or a stridor. Otherwise, foreign body. I have seen a lot of people chicken khate hain party mein. Okay, when they're having chicken and then they're drinking daru, their swallowing is not coordinated, and then chicken piece, chicken bone, fish pieces, they all get stuck over here, and they come with edema and stridor, inspiratory stridor, because they have supraglottic obstruction. All right, coming back to this question, saccule develops from D, pars inferior. Now guys, saccule here that they're talking about is a saccule inside the inner ear, utricle saccule, semicircle canals, cochlea. This is the saccule that you're talking about. Here, this thing that you can see over here, okay, this is the saccule that they're talking about. Ye wala. All right. And this saccule, basically what happens is this inner ear develops from something called as the otic vesicle over here. So this otic vesicle basically has two parts as it grows. So the part that is from the superior otic vesicle is called as a pars superior, and the inferior is pars inferior. And the utricle and the semicircular canals, this part is from the pars superior. The saccule and the cochlea is from the pars inferior. And that is how this whole division happens. Embryologically, this is important because sometimes from the pars inferior, the cochlea is not developed. The child will be born with congenital deafness and hearing loss, and will probably require a cochlear implantation. All right, so here's what is the zoomed in image of that. Okay, so the saccule and the cochlea are pars inferior. The utricle and the semicircular canals are pars superior. All right, and the other two choices are basically a part of the saccule. The anterior part of the saccule is anterior, posterior part is posterior anterior. It's not really, it does not originate from it. It is the part from it. हाँ प्रज्ञात सही हो यार, प्रज्ञात सही हो. कोई mnemonic यार, mnemonic. So when you look at the shape of this particular inner ear, right, you see that the cochlea is inferior. So it comes from the inferior part, and you see the semicircular canal is superior part. But आपकी मन की शांति को pure करने के लिए, clear करने के लिए, I know the kind of mnemonics you like. S for semicircular canal, S for superior, and C for cochlea, and oh, saccule भी तो S से है ना. That's why I don't believe in this mnemonics. All right, so you have to basically think logically. Semicircular canals are up, so superior, and cochlea inferior. All right, now somebody has written about angular acceleration. All right, there are three types of sensory cells that are there. So inside the cochlea, you have the organ of corti, which helps in transduction, conducts vibration to sound. In the saccule and the utricle, you have the macula, which is for linear acceleration, aage piche. And your semicircular canals have the ampullaris, crista ampullaris in the ampulla, and they are basically for angular acceleration. They are the sensors for that, and that's why these are the cells. All right, moving ahead, guys. We are almost 40 minutes through. Okay, what is the surgery done to widen the cartilaginous part of the external auditory canal? एक्सटर्नल ऑडिटरी कैनाल वाइडनिंग सर्जरी को क्या बोलते हैं? मियाटोप्लास्टी, टिम्पैनोप्लास्टी, ओटोप्लास्टी, मायरिंगोप्लास्टी. 4 plasties. What does a plasty mean in the first place? Plasty means repair. So what do you think? External auditory canal surgeries are called what? Okay, Sayantan has said A. Meastostomy. A. Most of you are saying A. I think some of you wait for 1 or 2 people to answer, फिर जो answer करता है वो सब answer कर रहा है. Nice. ये strategy exam में नहीं use कर सकते. You don't know what other people are answering. But I think maybe most of you are right also. It is A. It's very straightforward. Meatus is external auditory meatus, so meatoplasty is the repair of it. Kingslayer, thank you for putting one answer which is not correct. Tympanoplasty. And plasty means plastic surgery. Plasty means basically molding, repair. Okay. So we got tympanoplasty, otoplasty, meringoplasty, and meatoplasty. Now meatoplasty is very straightforward. See, meatoplasty is this one image over here. So some people, their canals, you see this external auditory canal, they will be narrowing. All right. So what we do is basically cut that part out, put in another cartilaginous flap, and widen it. Here also you can see that there's a little टेढ़ा मेढ़ा, इसको कुछ सुनाई नहीं देता. पेरेंट्स मस्ट बी लाइक कि हमारी संतान नहीं है. देन डॉक्टर के पास ले गए होंगे, डॉक्टर ने बोला मैं इसके कान खोल देता हूँ, एंड देन दे डू अ मेटोप्लास्टी, एंड नाउ ही कैन हियर एवरीथिंग. Now he's taking bath most of the time. All right, so so this is meatoplasty. All right, now this one over here, which you see over here, this is a myringoplasty. Guys, what is the difference between a myringoplasty and a tympanoplasty? What does it mean? Because myringitis is inflammation of the eardrum, so eardrum basically means myringo. So what does it mean that, what is the difference between myringoplasty and tympanoplasty? Both are are same. Meringoplasty is basically type 1 tympanoplasty. Meringoplasty is basically type 1 tympanoplasty. 5 types of tympanoplasty because life में complications कम है. Ankit is like, first we do meato or canalotomy only if there is narrowing of the canal, Ankit, otherwise ऐसे पैसे नहीं कमाने का है. Okay, so अगर problem है तो करेंगे. Merengo is only for the eardrum, that is correct. Actually tympanoplasty is also repair of the eardrum, but there is an artificial graft that is placed somewhere in the middle, middle ear area. If the graft is just patching the hole in the eardrum, then that is basically just called meringoplasty. Like ossicular reconstruction may or may not be there, but yeah, the ossicular reconstruction may be there because you will place the graft somewhere on the bone. So type 1 meringoplasty, you will place it on the handle of the malleus where it should be, but in type 2 handle of malleus is not there, so you will basically put it somewhere on the incus. And type 3 is basically where you will say, okay, all the ossicles are not there, so you will put it in the oval window on the stapes, okay, so that directly goes. And then type 4 is where it will then be put on the round window, and type 5 is where it will be put on the horizontal semicircular canal. So based on where you can get the thing is the tympanoplasty. All right, so we are underpaid. Okay, बिना NEET UG PG के भी दे सकते हैं. Great. So guys, in this कौन बनेगा करोड़पति, you will not win any amount of money. In fact, अगर आपका NEET हो गया, then you will lose 3 to 10 lakh rupees. अगर आप नहीं क्लियर करते तो आपके पैसे बचे रहेंगे. Somebody is saying this. सर आपकी क्लास कोई लंबी क्लास है on full ENT? हाँ भाई, that is what full ENT is not possible to do in rapid revision. That's why we are doing PYQ, so that you get most common questions that are being asked either from the options or this. 40 to 50% questions will come from this, and 40 to 50% of questions will come from something that I will share with you at the end of the class, which is not too far away. But stay tuned for that. All right. So guys, different types of meringoplasty. Type 1 is just the drum repair meringoplasty. Type 2, you place it on the long process of the incus. Type 3 is where you do a stapedopexy. You fix it onto the foot plate of the stapes, or then afterwards you can put it on the oval window, and then semicircular canal. All right, so this is it. I thought otoplasty is a made up word. You must have also thought otoplasty क्या है, तो ऐसे ही डाल दिया होगा. No, actually otoplasty is a plastic surgery of the outer pinna. The pinna repair is called as the otoplasty. Lot of people look like chamgadad. They have this bat ear like this, it comes like this, monkey ear, bat ear, the ear comes like this. So sometimes it has to be directed back like this, nahi to shadi nahi hogi. And all of that also gets affected. And that's why you do otoplasty. Hug Ultimate, you don't reply. I'll reply to all your questions. So I'm teaching now. So guys, here's one thing. If anybody wants to ask me some question that you want me to reply after this class, I'm going to be online for the next 1 hour, and I will only sit dedicatedly and reply to anything that you put in the comment section, whether there are questions related to ENT or anything else, and I will reply to it. Okay, aisa nahi hai that I know. Thug Ultimate, don't be hurt, yaar. If you get hurt, then as a doctor we'll have to treat you. Okay guys, this is this. The Thug is trying to get attention. JJ is also trying to fight for attention. Or ye JJ or Thug ka ultimate battle chal raha hai idhar. All right guys, now next question. I won't waste too much time. Cough or scratching the external auditory, the external acoustic canal is due to when you are scratching or stretching the external acoustic canal. What is the reason for cough? Auriculotemporal nerve, auricular branch of vagus nerve, great auricular nerve, or facial nerve. What causes cough when you're doing an ear examination? Because of, or if somebody is scratching the ear canal for a long period of time and they start coughing, what is the reason for that? Okay, all of you are saying B. Guys, this is a very important question. This has been asked many times also, and I learned this from personal experience. Because when I was doing an otoscopic examination and patient started coughing, and the senior HOD got really worried. He's like, why is this patient coughing? You're examining properly. I'm like, I'm examining properly. And after that, the patient developed a vasovagal syncope, and the reason why it is, the class is asking, class will get over in the next 1 hour, 1 hour max, 1 hour 15 minutes, right? So there is a nerve supply of the vagus nerve, the posterior canal, and when you stretch that, it's a parasympathetic response.
that supplies the respiratory musculatures for cough, and also the heart to cause bradycardia. And that's why it's very dangerous for any ENT examination. You can when, especially in the ear, if you pull or stretch a lot, when my parents used to pull my ear, "Idhar aaja," and you start coughing and you start crying after that, that is basically because of vagus nerve. And it's called the Arnold's nerve. Somebody has wrote it correctly, Arnold's nerve. And here is the nerve supply of the outer ear, and the pinna and the external auditory canal is important, guys. The wala part important hai, posterior inferior part. Okay, this is the tympanic membrane, as your cone of light will be like this. Is this posterior, this anterior, right? So the cone of light will be like this, and posterior inferior part is the auricular branch of vagus nerve, where we put most of the stress. And then the auriculotemporal nerve is supplying the anterior part, and facial nerve. Remember keratosis obturans, if the facial nerve is in close proximity, so it expands, it can cause facial nerve palsy. And your fourth choice, which was lesser occipital nerve, is coming from the C2, C3 spinal nerves. And this is the nerve supply, and then Arnold's nerve is the most important part. All right, guys. Now, this is an important question, guys. Following road traffic accident, person suffered from skull fracture, and below is the clinical finding. What is this mark behind the ear? It is not a fashion tattoo. This is something that has happened. Is it a battle sign, Bisol's abscess, mastoiditis, or Grisenger's sign? What is it? Battle sign, Bisol's abscess, mastoiditis, or Grisenger's sign. This is after RTA, skull fracture, head injury. Most of you are answering A, and A is the correct answer, battle sign. Most of you think that battle sign is because you have gone into some battle and head injury ho gaya hai. No, these are British names, and British names are like our Farsi names. जैसे हम लोग टोपी वाला, बाटली वाला, दारू वाला, जो profession होता है उसके ऊपर नाम बनाते हैं. वैसे the British also put names on their profession, like butler. And there's this guy called Battle who identified this, and William Henry Battle is the one who described this in the late 100s. But guys, battle sign is bruising over the mastoid process. It causes mastoid ecchymosis. So basically all that, it's basically just a bruise. All bruises are of this kind of a color that is there over here, and that is what battle sign is. Now, why have they given you these other options? Okay, this is important to know. Each of these is a potential question. They've asked you Bisol's, mastoiditis, Grisenger's sign. All of them show something behind the ear. That's why they've given it to you as questions to confuse you. And they can show you an image also, and they can ask you which of these, because they all look quite similar with slight differences. And that's why I wanted to pay attention to the next few slides. Okay, now this, what is this? This is a very shiny stretched skin at the back of the ear, typical of mastoiditis. It's a mastoid infection. The children can have ear infection. That ear infection involves the mastoid hair cells. They can have mastoiditis, and they have kan mein dam, and then for the house it becomes naak mein dam, and like that. So this is basically mastoiditis. All right, and what is this? Now, Bisol's abscess has been asked either directly or indirectly in various ways. Okay, either it is an option जिसको कोई चुनता नहीं है, जो गलत होता है, or it is sometimes the correct answer. But Bisol's abscess is basically a complication of mastoiditis. So you saw the mastoiditis, the child last, that same mastoiditis becomes pus, and yeah, ironed out mastoiditis is mastoiditis. If that mastoid abscess pus drains down, as you can see, if it drains down towards the sternocleidomastoid muscle and it comes down towards the neck, like you can see over here, that is called as the Bisol's abscess. And if the same abscess starts draining down towards the posterior belly of the digastric, which is this area, posterior belly of digastric, this area, that is called as the Siteli's abscess. Siteli's abscess. This is the only part of ENT which I find not so nice, because a lot of these are common sense, but किसी ने अपने नाम पर रख दिया यार, Siteli मेरे नाम पर रख दो, Bisol मेरे नाम पर रख दो, Battle मेरे नाम पर रख दो, and because of the name it's hard to remember. It's got no relation with the actual problem, right? So if they call inframastoid sternocleidomastoid abscess would be so easy, right? Or posterior belly of digastric abscess, belly abscess ही बना दो, that also can be done. but you know, Citelli and all of these, that's why these questions are asked, because they're confusing and you can forget them. So isko ye पूछते हैं. But they are both complications of mastoid abscess, which is a complication of mastoiditis. The pus drains into the sternocleidomastoid, it's Bezold's, and when they go into Citelli, yeah, because they want recognition like Thug Ultimate. So there will be a Thug's abscess soon, also very soon, maybe. We will see. All right. Now, Grissinger's sign is basically again edema of the posterior or post-auricular soft tissue, and because of the thrombosis of the emissary veins. Now, see guys, this is also another complication of mastoiditis. Whenever there's inflammation, it spreads here and there. And sir, Citelli ek bar or please. Okay, quickly guys, Citelli abscess is basically, there are two muscles over here that is below the mastoid. There is the sternocleidomastoid attachment and the what do you say, posterior and anterior belly. This is a posterior belly of digastric muscle ka attachment. And when there is a posterior belly of digastric muscle, isko hata dete hain. So when there is a posterior belly of digastric muscle over here, if the abscess trickles anteriorly, it is Citelli's abscess. If it trickles posteriorly into sternocleidomastoid, it is Bezold's abscess. And okay, so yes, Thug Ultimate, you got your recognition. Now coming back over here, lateral sinus thrombosis, some of you are telling correctly. Sayantan is very regularly telling correctly. So Grissinger's sign is basically edema in the posterior auricular space because of lateral sinus thrombosis or thrombosis of the mastoid emissary veins. Again, it's a transmission of this thing. So guys, history is very important. Like I always said, in the question, if there is trauma, it is most likely battle sign. If there is fever, infection, pain, restricted neck movements, it is one of these Bezold's or Citelli's. If it is not painful, but there is this thing behind with some history of you know, infection to the brain or some sort of a coagulopathy, then this could be the reason. Grissinger sign. All right. Okay guys, now this is a very itni baar aata hai, dimag mein dam kar diya this particular question. Surgery where one nostril is partially or completely occluded is done for which condition? It's a very straightforward question. We won't spend much time over here. There's vasomotor rhinitis, allergic rhinitis, invasive aspergillosis, and atrophic rhinitis. Atrophic rhinitis बोलने में अच्छी आवाज आती है because it makes my voice very roomy. Atrophic rhinitis. Now, atrophic rhinitis story is this, guys. And you know, these Brits, no, they're a little mean sometimes. Back, I think in 1960s or something like that, there is somebody who developed atrophic rhinitis. Atrophic rhinitis is a horrible disease. मतलब एकदम बास मारने वाला disease. And it is brutal because you don't come to know बास आ रही है. You know, अगर खुद पता चले, you do something about it, right? You have merciful anosmia. इसको बख्श दो, इसको मत smell दो. But it's really bad, foul smelling smell that comes to other people. कि सब दोस्त वो सब छोड़ गए. And वो stand up comedian बन गया जो भी था. But afterwards there's this doctor called Young who's very old, and this question is also very old, but this young guy is like, you know, the smell is the issue, so I will close the nasal cavity. And what he did is he basically took this you know, the took a flap from one side of the skin, other side of the skin, and he just stitched it together and put it on his name, Thug Life, कि हाँ ये मेरा you know, Young's operation है. But 2 years later when he opened it to see, the disease vanished. And that's how that became a regular practice to do this Young's operation, where, you know, they suture it and open it after a couple of years. Then there was a modified Young saying that, okay, there's too brutal, you also need some aeration. So they leave a 3 millimeter opening inside the nose, and after that 12 to 18 months they recanalize it, and most of the disease reverses over a period of time because the underlying cause is usually some autoimmune, some chronic inflammation, poor nutritional status, hereditary, iron deficiency, anemia. All of these can be reversed, and when these things can be reversed, you know, it becomes all right. It's like shut down and restart computers, जो हमारे बहुत ही अच्छे engineers सीखते हैं अपनी engineering में. Shut down and restart. This Young ने भी वही किया, बंद कर दो, 2 साल बाद खोलते हैं, and it is fine. And that's a Young's operation. And modified Young's operation is basically for the newer one that is done, where you make a tiny hole there. All right, it's smelly in it. Oh yes, it's smelly, you know. You can't take that smell, you know. It's all good comes and stinks up the place. Because close it up, Young. Just close it up. Okay, guys. All right. You can skip question 10. Yeah, we will skip it. Now, what is vasomotor rhinitis? There's this question that has come. I put all this text over here because when you get the annotated PDF, you don't have to remember or look at my very bad handwriting, which I got after a lot of training, because पहले मेरी handwriting बहुत अच्छी थी, but patients नहीं आते थे. And once I started scribbling, a lot of patients started coming, and a lot of pharma companies also started coming, because when I used to scribble, they used to give whatever they want. And I think that is the little secret of medical practice. So I have bad handwriting and a lot of patients. But guys, here vasomotor rhinitis is basically rhinitis, runny nose, profuse runny nose happening not because of allergy or not because of an infection, but because of a nerve called the Vidian nerve that is oversupplying its secretions to this to the end of the back end of the inferior turbinate and causing a lot of runny nose. And this Vidian nerve is basically a combination of greater petrosal, deep petrosal and ascending sphenoidal branch. बहुत ईगो है यार इन सारे में, हर चीज ग्रेटर है, बिगर है, मेजर, माइनर, ग्रेटर, डीपर, शैलो, सुपरफिशियल. अरे यार एवरीबॉडी इक्वालिटी है ही नहीं यार. कीप इट ऑल नाइस यार. लाइक पेट्रोसल नर्व एक ही रख दो ना. व्हाट इज दिस ग्रेटर है, एक डीपर है, क्या वो ज़्यादा इमोशनल है क्या डीपर पेट्रोसल नर्व, जो हमेशा डीप रखता है? और ग्रेटर पेट्रोसल नर्व इज ग्रेटर ascending sphenoidal branches. These are all close by, guys. The sphenoid is close and the petrosal area is there because of the location. That's why they named it like this. What we do is we take a 70-degree endoscope, enter the sphenoid sinus. On the floor we find the Vidian nerve. उसको खोरेद के निकाल देते हैं, या part of it we ablate it, and then all that blood supply to the posterior part of the lateral wall of the nose stops and the rhinitis stops. Vidian nerve is an important part for vasomotor rhinitis. बाकी जो options थे, that's not really conflicting, because allergic rhinitis and invasive aspergillosis, you don't really have a lot of foul smell and those kind of issues. So tell me something about yourself. ये क्या मेरा इंटरव्यू चल रहा है क्या भाई? मेरे को ऑलरेडी नौकरी मिल गई है. Okay, where do you see yourself 5 years from now? I hope not in this same comment box. Okay, and what is the occipitomental view with an open mouth, also known as? So when somebody was answering the viva and somebody takes an X-ray, so what do you call that X-ray? Open mouth है, question नहीं पता, answer नहीं पता है. Okay, so that is there are laws views. मेरा कोई इज्जत है ही नहीं. Okay, there is laws views, towns views, waters views, and Stenver's views. Guys, open mouth X-ray view, which one is it? Open mouth X-ray view, which one? C. Most of you are saying waters view, waters view. Most of you already know that answer, so we won't spend much time over here. Okay, what is laws view? Anybody know what laws view is? Laws view is basically the view of the mastoid. Okay, it's basically the mastoid, and it's basically to see the dural and sinus angle, sinodural angle. Sometimes before ear surgeries, it's important to see the sinodural angle. If it's a very acute angle or very obtuse angle, you need to know when you're drilling with the mastoid bone. So use the laws views for the mastoid. Okay, and this other view, the towns views, to basically see ki bheja hai ki nahi. It is basically anterior posterior view. Most of them are posterior anterior PA views, but this is anterior posterior. It's going from up to down like this. It is mainly to look at the foramen magnum shadow and all the structures that come around it, and it is not really relevant in ENT. All right, and here is where you see the mouth open 45 degrees. Another question that is asked when it comes to Waters view, and this is the mouth open. You open the mouth to basically see the sphenoid sinus, because the sphenoid sinus is right behind the nose and just above it, right? So when you angle and you open your mouth, the X-ray radiations can go in and get an image of the sphenoid sinus, but mainly you can see the maxillary sinus. In X-ray, whatever is white is bone, and whatever is black is air, and whatever is a little gray is going to be either tissue or infection or inflammation and all of that. Stenver's view is another view to see the mastoid, but it is a little zoomed out view. So you can see over here, the Stenver view is a bit more zoomed out view at 45 degrees posteriorly. So in this particular question over here, Law's view is mastoid, Stenver's view is mastoid, and Town's view is skull, and it's an AP view, and Waters view is the only one that you use for sinuses. तो कितनी सुंदर हैंडराइटिंग है मेरी. इसको किसी फार्मासिस्ट को दिखाओगे तो अभी आपको 4 मेडिसिन दे देगा. Okay, what is occipitomental? Oh, Dr. Shraddha is also giving some additional points. So look at what Dr. Shraddha is also writing. Okay. Now, guys, 9-year-old boy comes with complaints of right ear pain, difficulty opening the mouth, not because parents have told to keep quiet, but because cannot open the mouth, painful swallowing and fever. Oral cavity examination reveals this. What is it? Is it a parotid abscess? Is it a pharyngitis? Bisolt's abscess, which you already know what it is, and quinsy. What is the answer to this question? Tarakanta Das PRA. Parotid abscess, pharyngitis, Bisolt's abscess, quinsy. Quincy. Most of you are answering Quincy. What is Quincy? Quincy is. Can anybody write? Okay, D to aap likh rahe ho. Do you know what Quincy is? Can someone write what Quincy is? What is Quincy? देसी कलाकार ने D 4 बार लिख दिया 4D में. Very nice. 3D, 4D. But what is the Quincy? Peritonsillar abscess, Quincy, Sayantan Basu, सही जवाब. And Anamika ने भी peritonsillar abscess दिया. Yes, it is peritonsillar abscess, guys, that causes all these problems. It's peritonsillar, around the tonsil, tonsillar capsule, peritonsillar area. It's a complication of tonsillitis, and that basically causes usually a unilateral peritonsillar pain, and because of this area there is pain, and there's jugulo-digastric lymphadenopathy, and all of that is very painful swelling, and sometimes can cause difficulty in breathing also. All right, uvula is pushed to the other side, and sometimes there could be the uvula which is also swollen, called uvulitis, and this is has to be drained. Okay, after a good course of antibiotics, you have to do incision and drainage with a big suction, Yonker suction, or a good suction catheter, and drain out all the pus. All right, that's why good idea to just gargle after you eat anything that gets collected in the crypts. All right, so there's nothing much to talk over there. Now, guys, mitomycin C बहुत बार पूछा जाता है. Following drug is used in which condition? Mitomycin C is used in which condition? Subglottic stenosis, rhinocerebral mucormycosis, adenoidectomy, and tympanoplasty. Where do you think you can use mitomycin C? Oh my! Everybody saying A, very good, and JJ saying B, rhinocerebral mucormycosis. सबसे लंबा जवाब दूंगा मैं. All right, but most of you are saying A. Atharva is also leaning now towards B, and A and B के बीच में AB baby, A company का नाम था जो fail हो गई थी, and AB baby and subglottic stenosis. That is correct, guys. If you know what mitomycin C does, answer is very clear. The reason why mitomycin C is not only used in ENT, it's used in gynecology, used in breast cancer, used in everywhere, many parts of the body, because mitomycin C does something very important for a surgeon, is that it prevents a form of fibrotic healing, which can cause unnatural bands. So whenever you want to, when there are very close mucosal surfaces and you don't want them to stick together, mitomycin C is a very good one. Can anybody tell what is mitomycin C? Is it an is a chemotherapeutic agent, or what is it? What is mitomycin C? Mitomycin C, it prevents synecdoche and scar formation. Correct. That's the main reason why it does that. Mitomycin C is actually an anti-neoplastic antibiotic, and it is derived from a bacteria called Bacterium streptomyces cespitosus. Without spitting, you cannot say cespitosus. And it inhibits fibroblast proliferation, because of which you do not have scarring, and it modulates wound healing. Also used in corneal atresia repair, or anywhere where you're going to get, even in sometimes very close to the septum, and the nasal wall, we sometimes use mitomycin C. In stenosis of the trachea, mitomycin C. Corneal atresia, mitomycin C. Many of them. It's an anti-metabolite. Keshav, you're correct, but it's an antibiotic from it's an anti-neoplastic antibiotic, because it is also coming from bacterium, and it also kills certain bacteria. So that is what it is. Sana Farheen बहुत खुश हुई suddenly. Why? Yeah. Okay. All right. We are halfway through, guys. Just a few more questions, and we then do some other things. All right. Now, guys, this is a very sticky area for me, because जब thyroid आ जाता है ENTs वालों को बहुत खुजली होती है, And there is this, jugalbandi between surgeons and ENTs, because when surgeons find a patient with thyroid and they want to do thyroidectomy, unfortunately they have to send to us because we have to document the vocal cords. And when we document the vocal cords, we also start talking to the patient and say, हम भी thyroid surgery करते हैं, and यहाँ आ ही गए हो तो नेकी और पूछ पूछ. And then eventually we operate on thyroid as well. Like I said, ENT is cancer of medical field. हम लोग हर जगह घुस जाते हैं. So following thyroidectomy, patient develops difficulty in breathing, and whatever repeated attempts to extubate is unsuccessful. What is the most probable cause? Hematoma. हेमाटोमा तो धर्मेंद्र का एरिया है, हेमाटोमा वही कर सकते. And unilateral recurrent laryngeal nerve injury, bilateral recurrent laryngeal nerve injury, and superior laryngeal nerve injury. What is the function of uvula? The function of uvula is that when you scream, वो uvula हिलता है. It basically modulates some of the voice, and it maintains some of the blood supply and vasculature in the center part and maintains equilibrium. Whenever somebody answers like that, that means उनको कुछ नहीं पता और वो कुछ भी बोले जा रहे हैं. Uvula is kind of rudimentary, and sometimes it is not even there, but sometimes it is very prolonged, and maybe after some point of time it will also disappear. So now guys, what is a nerve that we cut, which can cause this kind of a problem in extubation, is going to be recurrent laryngeal nerve. Okay, now guys, here's the problem why recurrent laryngeal nerve palsy is so dangerous and such a problem. Because if you look at the intrinsic muscles of the larynx, all the muscles, transverse arytenoid, oblique arytenoid, lateral cricoarytenoid, they are all adductors. Matlab, you can see they bring the vocal cords close. They are adductors. They bring the vocal cords close to each other. They adduct. There's only one abductor muscle, and that abductor muscle's job is to open the vocal cords wide. And if this gets paralyzed, everything becomes adduction, because this is anyway going to be an adduction, because it's an adductor. And because the abductor is stronger than the adductor, patient will develop stridor, because this whole thing will close, and the moment you extubate, the vocal cords will close, or they will open partially sometimes depending on the tone of the muscle, and they will develop either aspiration pneumonia, but most likely both vocal cords will be in adducted position, and cricothyroid muscle will be intact. But cricothyroid muscle is the only muscle that is supplied by the superior laryngeal nerve. So all intrinsic muscles of the larynx are supplied by recurrent laryngeal nerve except the cricothyroid, which is supplied by the superior laryngeal nerve. Superior लोग कुछ काम नहीं करते ज़्यादा, वो बस मैं एक ही मसल को दूंगा क्रिकोथायरॉयड, जिसका काम है टोन करना. बिटवीन द क्रिकॉइड एंड द थायरॉयड मसल इट जस्ट टेंसेस द वॉइस अ बिट, द वोकल कॉर्ड्स. बाकी सारा काम रिकरेंट करता रहता है, रिकरेंट नीचे से जाता है ऊपर से जाता है जोमेटो की तरह, and it does most of the job over there. So cricothyroid muscle basically helps in improving the tone of the voice, stretches the vocal cords. But adductor abduction, posterior cricoarytenoid is the only muscle that does abduction. When it is paralyzed, lead to stridor because of recurrent laryngeal nerve palsy. Right now, female patient, nasal obstruction, nasal discharge, loss of smell, yellowish green crust, found to have merciful anosmia. Can you see in the number of times these questions related to atrophic rhinitis, Young's, constantly being asked? The reason being that these have to be known, because all other things are very common. So this patient has a roomy nasal cavity, foreign body, inferior turbinate hypertrophy, or nasal polyps. Since you've already done this, guys, what is the answer? It's A, of course, roomy nasal cavity. Let me show you what a roomy nasal cavity looks like. This is a normal nasal cavity. If you don't know what the endoscopic image of the nose looks like, can you guys tell me this is the right nasal cavity or the left nasal cavity? Right or left? In real life, you will know because you will see your endoscope in that nasal cavity. But in the questions they sometimes ask, to just understand the landmarks, endoscopically, is this a right nasal cavity or a left nasal cavity? Can you guys make out? This is a right nasal cavity. Snippo X kilo is X kilo. But Jafar Iqbal is saying left. Somebody is saying right, somebody is saying left. Right is left is right is left is. Okay, here's a simple way to know it, guys. Inside our nose, the lateral nasal wall has turbinates. Okay, you can see this is the inferior turbinate. This is the middle turbinate, right? And the superior turbinate is above. Okay, it will be somewhere here, superior turbinate. So this is the lateral nasal wall, and if this is lateral, then this is the septum. So this is the right nasal cavity, right? And sometimes, you know, some structures you may need to recognize, otherwise you won't know what it is. Okay, so you can see the right inferior turbinate. It's a nice thin turbinate. You can see the middle turbinate. You can also see, you know, a little bit of this is called as the agar nasi cell. You can see a little bit of the uncinate process. So it's a very, you know, good spacious, but this is a normal nasal cavity. Now, when you go inside somebody who has atrophic rhinitis, you see these yellowish crusting over here, right? You see there's all this yellowish crusting, and you see there's a lot of space over here. The inferior turbinate is so thin, there's a lot of space. That's why it's roomy nasal cavity crusting inside the right nasal cavity, and that's why you do the Young's operation for this. Close it, allow it to heal, and you come back. And there are also a lot of other medications that you give along with that. Inferior, other options that were there, which is the inferior turbinate hypertrophy. This is the left nasal cavity. This is the septum, and this is the inferior turbinate on. So this is the left nasal cavity. Such a large turbinate. Usually this large turbinate will be seen because there will be deviated nasal septum, you know, on the other side. All right, and this over here, you can see, move this up here. This pale structure is the nasal polyp. So none of these other things like nasal polyps or inferior turbinate is going to have a roomy space. Roomy space is only going to come in atrophic rhinitis. All right. Now, guys, patient presents to the emergency with epistaxis, and there was no relief from pinching the nostrils also. Okay, Trotter's method did not help. वो question का भी कोई फायदा नहीं हुआ. And nasal packing is done, but patient continues to bleed. They're not asking you the diagnosis, even though that will be interesting. Why is the patient having bleeding even after all of this? But what would be the next appropriate step in the management of the patient? Okay, which artery will you ligate? Of course, they're saying you have to ligate. Will you ligate the maxillary, carotid, sphenopalatine, or external carotid artery? Sphenopalatine artery. Oh, Sayadan Basu is written on Tespal. Wow, naya artery. Okay. So it is sphenopalatine artery, TELSPA. Okay, like that. Okay, so this is the sphenopalatine artery, guys, that we are going to be ligating. Sphenopalatine artery comes from the internal maxillary artery. Internal maxillary artery comes from the external carotid artery. Internal carotid artery does not really contribute to this, to the ophthalmic arteries and the anterior posterior ethmoidal arteries it does. But here is how the blood supply of the septum is. You have the anterior and posterior ethmoidal arteries that are coming from the ophthalmic arteries. Okay, ophthalmic arteries. Your sphenopalatine and greater palatine artery are coming from the maxillary artery, and your superior labial artery is applying to part of the face, superior part of the lip. It's coming from the facial artery. Okay, so that's why we want the sphenopalatine artery, because that is the most notorious and that is causing most of the bleeding. And B should be never. No, with Ankit, even with B, the bleeding will stop. Like if you ligate the internal carotid artery, bleeding will stop. You will be successful in stopping the epistaxis forever. That is why you stay away from the internal carotid artery, because you will also go away forever. So guys, yeah, internal carotid artery should never be ligated unless you know you are doing a surgery on the head and neck and somehow have to cut it and you have to like heal it. So Ankit Pandey is right. Okay, this is about it. Now, guys, post tonsillectomy. Tonsillectomy is very, very important. Post tonsillectomy patient starts bleeding from the operative site in the post-op room. So patient has undergone surgery and just come into the post-op room. On examination, blood clots are seen. But what will be your most immediate management? Guys, when they use the word management, remember it can mean both investigation and treatment. Sir, doppelganger Imran Hasmi, yes, but only in looks, not in kartut, not by choice. But guys, what will you do next? Now, if the patient has post tonsillectomy bleeding in the ward, will you shift to OT, remove the clots and ligate the vessel, or you'll say, okay, I'll give antibiotics and pack the tonsillar fossa, or I'll give anticoagulants and ask them to gargle, observe for 24 hours, or I will just directly do blood transfusion ना खून पड़ा हुआ है, हम डालेंगे वो निकलेगा, हम डालेंगे निकलेगा, खून की नदी बहेंगी, क्या करना है? What do you think is the right approach? These next step questions are always going to be very clinical, reactionary, hemorrhage. Yes, this is reactionary hemorrhage, which is basically once you do the tonsils remove it, the reaction of it is it's basically because of the relaxation of some of the blood vessels walls, and it can cause reactionary hemorrhage. But guys, yeah, some people are saying D. We will do blood transfusion. बहुत पड़ा हुआ हमारे पास खून. Okay. Some people say we will do A, and then there could be slippage of ligatures. Guys, okay, see, the answer is in the choices. Okay, first of all, they're saying clots are there. Okay, so now will you shift back to the OT, do IV antibiotics, and pack the tonsillar fossa? Very not easy to pack the tonsillar fossa and cause a risk of the packing to fall down. So usually that is not generally, if the packing of the tonsillar fossa is there to wait for the bleeding and then remove the pack and then again try it again, that's typically not done. You remove the clots and you ligate the vessel would be the approach. Why would you give anticoagulant? It's already bleeding. The clot is the one that is stopping the bleeding. The or bleed karega if you give anticoagulant, so that you cannot do. Blood transfusion also is not practical. So guys, here is the blood vessels. Most likely a branch of the lingual artery or the tonsil artery, which is the branch of the facial artery, is the one which is ligated and accessible. Sometimes because the arterial wall recoils and goes inside, it's very hard to catch it, and sometimes that becomes very, very difficult and tricky and life-threatening situation. So surgeon's skills to basically go in and catch that particular vessel, religate it, or you cauterize it is something that has to be done. Very, very scary situation, but tonsil surgeries are very, very common, and if you do the surgery correctly and do the right intraoperative procedures, usually you don't see this happen. But ligate. Okay guys, this is a very simple question. Okay, sometimes it is like moral boosting के एक simple सा question भी पूछ लेते हैं. Patient had chronic ear infection, had fever, headache, vomiting, irritability. CT brain is shown. What is the possible diagnosis? This is basically just checking your anatomy of the brain because you can see the abscess. All you need to do is tell the location of the abscess. What is the difference between reactionary hemorrhage and primary hemorrhage? See, a primary hemorrhage would occur. Generally, the word primary means there would be no cause for it. A reactionary hemorrhage could be post-surgery, post-ligature slipping, post coughing or something like that, right? But a primary hemorrhage would usually have a cause. Okay, so here guys, it's a temporal lobe, very, very straightforward. If you see the brain, this is the frontal lobe, this is the temporal lobe, this is the occipital lobe is behind, this is the cerebellum, and here you can see that this is in an abscess in the temporal lobe. So it's very, very straightforward. Temporal lobe abscess, इसमें time waste नहीं. Okay. Now this is an interesting question, especially post-COVID. You can expect COVID-related questions, and in ENT, some of the common or important COVID-related questions are always related to mucormycosis. So post-COVID, diabetic develops unilateral facial pain, loosening of the teeth. Which investigation will you do to confirm the diagnosis on this patient? और कितने क्वेश्चन बाकी हैं? जे अभी 8 more questions बाकी हैं. We should be done in the next half an hour. Ankit Pandey, do you teach anatomy also? Nahi re baba, anatomy. I really loved anatomy in my MBBS days. I love studying it. I don't love teaching it. I love studying anatomy. I did it for 2-3 years actually. Okay. How do we differentiate abscess and tumor? Abscess is fluid inside it. Tumor will be hard and it will have tissue inside it. So generally, even when you do examination, it will be cystic, transillumination, all of that will be there. Tumor will be hard, all of those things. But if you do a CT scan, you'll come to know. Okay guys, so now what is the answer to this? Somebody saying biopsy with histopathological examination, somebody saying MRI. एक ये ferritin को भी बोल दो यार, कोई ferritin को कोई नहीं ले रहा, HbA1c नहीं. Okay, so there's confusion between biopsy with histopathological examination and MRI. Guys, let me tell you one thing. Anytime in any question you see the word confirm, and if you see any histopathology or biopsy, nothing else can beat that. Everything else, there will still be an indicative joke. MBBS synapse is saying, sir, tell a joke. A joke. Okay. Now, to confirm, when the word confirmation comes, it basically means that it has to be biopsy or histopathology. Nothing else can confirm it. It can give you an indication. It can give you a supportive thing. HB1AC can give you a supportive thing. Yeah, this is diabetes. Serum ferritin can show this ferritin level. MRI can show you the findings. But whenever the word confirmation comes, अगर कोई भी biopsy histopathology का option है, that basically is a clear-cut answer because that is the gold standard and final. What you see it in pathology, it is there. So what do you see when you go into mucor? You see aseptate. A mucor is basically a part of the zygomycetes mycetes group. It is non-septate hyphae. Most people think that septate basically means branches, okay, but septate is basically, you know, these kind of lines that come. Septate hyphae will be seen in aspergillosis over here, as you can see these septates that are there over here, right? So when it's aspergillus, you'll have these septate hyphae. And what will be biopsy snippo ke kilo is asking. There, when you go inside the nose, you take the mucosa over there, no, the mucosa which is all being necrosed and all of that. You will take a biopsy of that tissue. Can be from the turbinate, can be from any of the structures that is there. You send it for histopathology. That tissue will basically show this. All right. So broad-based aseptate hyphae, correct. देखो कितना मोटा है, you know. This is lean. ये jogging करता है. Intermittent fasting, jogging. ये वाला मोटा लेटा हुआ है इधर. Okay. So mucor. So that's why basically, and yeah, obtuse angle. So a lot of you know a lot of these kind of things. There's obtuse angle over here, and there's acute angle over here. All right, guys. This is what the mucor will look like. This is what you will take the biopsy of. Okay, all this black charring, fungal infiltration, eating away the blood vessels and spreading to various parts of the questions. You know, that is basically what causes. This is what you send for biopsy, and this is what mucormycosis looks like. Right now. Patient presents with the complaint of inability to close eyes, drooling saliva, deviation of angle of mouth. It's the examiner look. Yeah, kuch nahi pata hai kya? Okay. And which of the following nerves is most likely to be affected, guys? Trigeminal, facial, oculomotor, glossopharyngeal. It's very, very straightforward question that you can answer. Okay. Okay. Guys, what is the answer for this? Yep, you guys are right. Facial nerve and facial nerve के ऊपर कुछ ना कुछ क्वेश्चन आता है, not only in undergraduate, even postgraduate, even ENT के बाद हर जगह facial nerve is extremely important, for the face, and it supplies all the facial muscles. If you want to learn what facial palsy is not, then you watch this movie called Guru where Abhishek Bachchan ulta करता है, but that is called another kind of palsy. Bell's palsy. Okay, Bell's palsy is basically when you don't know the cause of the facial palsy and it is idiopathic, that it is called Bell's palsy. मतलब घंटा कुछ नहीं पता तो Bell's palsy है. That's why Bell लगा हुआ है ना उधर. Okay, so that is Bell's palsy. But if you know the cause for the facial palsy, it could be something else. There's a Ramsay-Hunt syndrome which is there, and the Ramsay-Hunt syndrome is not a horror movie with Ramsay. I don't know, most of you will not even get it, but in my days used to have these two Ramsay brothers who used to make Ahart and Z horror show and all of that. So, and it's got Ramsay-Hunt, though horror naam isme hai. You used to remember it that way. So Ramsay-Hunt syndrome is basically herpes zoster, and there could be facial nerve involvement with facial palsy, and so there is a name for it. But agar ghanta nahi pata, Bell's palsy. Okay, so that is what it is. Okay, guys. Now, change the color of this. Now this is what the facial nerve palsy is there. It's a lower motor neuron palsy, which means that even the forehead and the eyebrows are affected. So you will see that the side of the paralysis, this is the area where the paralysis is. Okay, this side there is the paralysis. So here you can see that you are not able to do frowning. You are not able, this lip is drooling down, nasolabial folds are gone, eyes are not able to close, and when you are trying to blow air, it comes out. Like, that kind of thing. Please, I saw you performing in marriage function. How much you charge? Yeah, यार इधर तक से डिस्कस करेंगे ना ये सब धंधे का काम बाद में. किसका शादी हो रहा है? मेरा कॉमेडी शो के बाद टूट गया था शादी, फिर मेरे को 2 शो मिल गए. Let's not talk about that. But yeah, so facial nerve, guys. See, this is a very interesting diagram of the facial nerve. Will also be shared with you. But if you can see, the reason why this happens is when the facial nerve comes out from the cerebropontine angle over here, it gives a branch which goes to the lacrimal gland. That's why dryness of the eyes is an important symptom of facial nerve, palsy. And then it supplies to the stapedius. So you also have, hearing issues. And and then you have the chorda tympani, which supplies the anterior 2/3 of the tongue. Posterior is glossopharyngeal. And then of course all the muscles of the face, motor muscles, and the last 5 branches into the parotid: temporal, zygomatic, buccal, mandibular, cervical. That's why you have all of these particular symptoms. Sir, if there's trigeminal palsy is present, then will there be facial features? Trigeminal mainly is painful, pain, dard, chupta hua, sharp pains. But if the palsy is there, maybe the pain will go away, because trigeminal neuralgia is very, very painful. But trigeminal palsy will probably relieve pain. Facial nerve comes out just because of gym. Yes, this is nice. All right, cheek has all anatomical nerves only. All right, guys, so that is the thing. Now, don't get me wrong by this image, okay? Yeah, this is an image where somebody is trying to save somebody's life. So an adult man suddenly starts choking on his food. Chaba chaba ke khane ka, dheere dheere. He is conscious. The following procedure is being performed. What is happening over here? Guys, your options: Heimlich's maneuver, chest thrust. I don't know ये options किसने बनाए. Back slap. Wow. Blind finger insertion. My God. I am not going to spend much time on the other options for obvious reasons. But Heimlich's maneuver is the correct answer, just to avoid an awkward banning of me from social media and this. Okay, so Heimlich's maneuver, this back thrust is, sometimes you do this, sometimes, in children or adults, sometimes you do this back tapping, and basically you're saying, "Kyun khaya? Aise kyun khaya tune?" But you're basically trying to also push, the thing out. But Heimlich's maneuver is basically where you lock your hands and push at the sternum below, so that when you compress it, the diaphragmatic air will push things out from the airway. Most of these are basically, going to be supraglottic. Something that you've eaten that is just being stuck in the supraglottic or pharyngeal area. So if you are going to do a good Heimlich's maneuver, it's most likely going to come out. All right, back slap is for infants. You are correct. This pic is not hood. Okay. How to concentrate and learn while chatting? Very difficult. That's why we'll send annotated notes, and you can watch this video even later on. All right, guys, just few more questions left. Stay with me. And ENT is very chilled and relaxed, nothing about so much. Patient present with firm, tender, slow growing mass below the ear shown in the image. What is the diagnosis? देखो इसमें से Bizold abscess तो already is out. Now you know how important these things, these past questions are, because these options, they come again and again. So Bizold's abscess is out, but what is the choice? This tender, slow growing mass below the ear, parotid abscess, the firm and tender. Is it upper cervical lymphadenopathy, or is osteoma of the mandible? They do not obstruct completely, Ankit Pandey, but sometimes somebody has a very big chicken or something like that. It can get stuck. Yes, the correct answer is parotid abscess. Okay, now it cannot be Bizold's abscess, because Bizold's abscess is behind, going up to the sternocleidomastoid. Upper cervical lymphadenopathy is also over here. Osteoma of the mandible is different. So this has to be parotid abscess. Parotid abscess, as you can see, the parotid gland from its anatomical structure is just in front of the, this is the tragus, okay? This is called as a tragus. Just in front of the tragus se wo shuru hota hai, and this whole parotid gland is there. And when this parotid gland is inflamed or develops an abscess and a swelling, this happens over here. It's very painful while eating, because when salivation happens, it's extremely painful in parotitis. Especially parotitis starts because of dehydration, many times seen in pregnancy, or when something blocks this the salivary gland opening. And what is the difference between salivary gland and abscess? Gland is a normal gland that produces saliva. Abscess means there is pus that is now filled inside the parotid gland, causing this. Treatment, of course, is a good course of antibiotics and sometimes draining the parotid abscess, but you should be very careful when you drain the parotid abscess, because the 5 branches of the facial nerve go in different angles. Whenever you do a parotid surgery, it's very, very hard to preserve the parotid nerve, the facial nerve, and that's why the tragus is a very important landmark, because the facial nerve comes from there, and you have to then dissect the facial nerve really well. You can give any 3rd generation cephalosporins and all of that to treat this. Rehydrate and IV antibiotics. Pleomorphic adenoma will also, of the parotid gland, will also be over here in the same area, but you may not have this tense secretion. The parotid gland location is going to be same. So this is the parotid gland. Now, mandibular osteoma is a bony growth. It's going to be very hard. It's usually going to be along the joint, the angle of the mandible. Even if it's there over here, it can be very close to where the parotid gland is. So when you're going to touch it, it's going to be very hard and bony. It's not going to be firm or tense or red or having fever or those kind of things. So mandibular osteoma will be is going to be bony things. All right, it's going to be a bony swell. All right. Now, guys, this is an important question. बहुत बार आता है यार, and this is also very important for you clinically. Adenoma is painful, yes, sometimes because it's a tumor. It does infiltrate the capsule around and all of the structures nearby, and it can cause pain. A 5-year-old child presents with reduced hearing for the past 2 to 3 months. The otoscopy finding is given below. What is the most likely diagnosis? Pharyngitis bullosa, acute otitis media, serous otitis media, or pneumotympanum, guys. What is this? Reduced hearing for the past 2 to 3 months this child is having. Pharyngitis bullosa is the answer. Some people are saying serous otitis media. So Rose is saying acute otitis media. अब कोई D भी बोल दो, सारा हो जाएगा. CSOM, Priyanka is saying CSOM. Okay. So guys, this is not CSOM. See, I'll tell you, it's not cartwheel. Okay, a lot of you get confused over here. We'll spend some time. I'll clarify this to you, all right? Whenever you see this word S, no, suppurative, acute suppurative otitis media, chronic suppurative otitis media, suppuration means pus, infected material. If the infected material is there, especially in chronic suppurative otitis media, you will see a hole in the eardrum and you will see pus oozing out of it. So this cannot be chronic suppurative otitis. Yeah, all right. Acute suppurative otitis media, there are 3 or 4 stages of it, and the early stages of acute suppurative otitis media or acute otitis media, you can see, but you will not see such a clear, see, you see the cone of light is so clear. You can see fluid behind which is so clear, air bubbles. Doesn't look like there's any sign of infection over here. Okay, so if there's no sign of infection over here, generally acute otitis media and meningitis, which is also inflammation, will go for a toss. All right, and your answer will most likely be serous otitis media or glue ear. Yeah, it's also called glue ear, serous otitis media, secretory otitis media with effusion, you know, just to create confusion. Same kind of thing, different name. But if there is infection, that is suppuration. Okay, or meningitis will be there, it will be red. Like I'll show you what each of these look like. Okay, so here you can see nice clear watery air bubbles are there because your eustachian tube is equalizing air, na? So from the middle ear, the air is coming in and out. So all of this glue or this, mucus that is there is colorless, basically. So when these air bubbles go inside, they appear like this. It's very common. We have a lot of images that we take from our patients. They develop this kind of thing, and it's called glue ear, secretory otitis media with effusion, all of these kind of names. But what are the other ones, guys? Bullous meningitis. You can see bullous. Bullous basically means swelling. Whenever there is bullous, swelling. All right, you will see that. Yeah, now you can see it over here, right? So you can see there's this red bulla swollen, only inflammation of the tympanic membrane. Meningitis, bullous meningitis. You will see some vesicles and blebs also. Middle ear and external ear are not affected. Then only it's called bullous meningitis. It is the eardrum has become inflamed, and that has caused all of this swelling and this bullous appearance. Okay, when it is acute otitis media in the initial stages, you will see because of the pus, the mucopus, the eardrum is losing its translucency, and all the blood vessels are being seen, given this cartwheel appearance. And this attachment to the handle of the malleus, the umbo, that is firmly attached, so the rest of the area is bulged, so it looks like a cartwheel appearance. And because of the cartwheel, this cartwheel appearance is seen in early acute otitis media. Whereas bullous meningitis, you will see this bullous swelling. Okay, so I hope you're able to see both of these and appreciate the difference. All right, last 2-3 questions, guys. Patient comes with a history of asthma and sinusitis. On looking into his medical records, he has Samter's triad, which you must have also seen in my series. Which drug should be avoided in this patient with Samter's triad? Cotrimoxazole, co-amoxiclav, aspirin, or chloramphenicol? Thank you for watching my trailer. Ankit Pandey, which stage? First stage, the early stage, first stage of acute otitis media will show cartwheel appearance. Donut-like appearance, yes. Donut. थक गए सर? अरे अभी नहीं थके यार, तो सर्जरी करते हैं 10-20 मिनट. Alright, so guys, you're saying aspirin. See, samterstride also shown in the season 1 of my web series. Samterstride is basically, you have the features of the samterstride. You have sinusitis, you have asthma, and you have aspirin sensitivity. Too sensitive to aspirin. You know, thoda sa bhi aa jata hai, like, you know, some sensitive relationships. Aspirin intolerance, you cannot tolerate aspirin. Moment you take aspirin, it will cause adverse reactions, or any non-steroidal anti-inflammatory drug. Okay, it can cause rashes, abdominal pains, bleeding, all of those kind of things. So that's why, you know, if you see that a patient has sinusitis and also has asthma, and this is not very uncommon, because what happens is people who have asthma will also have allergic rhinitis, and allergic rhinitis produces a lot of nose secretions that get accumulated in the sinus and cause sinusitis. So to have someone who has asthma and sinusitis is not a very uncommon thing. You know, that's why they ask this question a lot. And aspirin or non-steroidal anti-inflammatory drugs have to be avoided. You can give certain other alternatives. And there is a Malayali tablet that is quite popular called paracetamol. In paracetamol, you know, moles, we can give it. And there's also a Malayali bacteria called Pseudomonas. Anyway, I'm going off track there, but you can use these. Okay, guys. All right, coming to the second last question. 70-year-old male patient, decreased hearing, high frequency, basilar membrane is affected. Which structure lies close to it? It's not telling you the type of hearing loss. Which structure is affected? Yeah, Dr. Atik, yes, ma'am asked the question during rounds and I got badly scored. I'm just tired. But guys, here, which is the structure closest to the basilar membrane? D. Some people are saying D, some people are saying C. Okay, is it helicotrema, oval window? Two questions: helicotrema or oval window? Anandu Anand, any Malayali, any culture Malayali area. I studied in St. John's, so Malayalam little bit comes by default. I'm also trying to get the moment I'll look, but not working out. Okay, so most of you are saying C, it's oval window. Okay, and you're right, it is oval window, and this is the reason why. Okay, so now this whole coil of this cochlea, all right, they're basically three compartments: scala vestibuli, scala tympani, and scala media. Now the scala vestibuli is basically the one that is attached to the oval window. All right, so the oval window is attached to the stapes. So when the stapes moves the scala vestibuli, this starts vibrating, it shakes the basilar membrane, and when it shakes the basilar membrane, you have that. The way it occurs is these waves, they travel like this, they come all the way into the scala tympani, they rebound from the round window. Round window is also called as the secondary tympanic membrane. This round window is also called as the secondary tympanic membrane. It's also very important because your electrode for cochlear implant is also going from here, and your intratympanic gentamicin and cochlear implant are through the round window. The reason why this round window is there to allow recoil, because all those waves that are there, the waves have to die down, so this recoil is there. So when these basilar membranes, they shake, these are there at the base, and base is high frequency. High frequency sounds cannot travel far away. Okay, they have low amplitude. That's why when you go to a rock show and you hear the bass of the drums, you'll hear the bass of the drums much far, because the bass is basically low frequency, high amplitude, travels far. So low frequency sound will go all the way up to the apex, and this apex where this hole turns, where your scala vestibuli turns into scala tympani, where it becomes like this, that is called as a helicotrema. It's far away from the basilar area. Okay, it's near the apex, whereas this round window or oval window are the ones that are going to be close to the base of the cochlea, and because the stapes is the one that is involved in the vibration, oval window is the answer over here. All right, there's an option called stria vascularis. Stria vascularis is in the lateral part of the scala media. Basically is a supporting cell. So you're an amazing teacher. Nobody taught medicine such a fun way in the history. Thank you so much, Ashay. Thank you. Uh, nice to get appreciated once. Okay, guys, I am here on my second last question over here. Okay, very simple question. कभी कभी बचकाने सवाल भी पूछते हैं. What structure do you see over here? Stapes, incus, malleus, or vomer? What is seen over here, guys? Stapes, incus, malleus, or vomer? Fairly straightforward, and I think you are getting the answer right. Yes, केशव नारायण सर, आपकी कंप्लीट नोट्स और वीडियोस कब आ जाएंगी? हाँ, आ जानी चाहिए यार. I mean, at least for this session you will get, and I'm also going to share a little surprise for you guys, a little thing that I've done from the bottom of my heart for all of you lovely guys out there, which I will give you very shortly now, 5-10 minutes. We're almost done over here. Hammer. Yes, it is incus, guys. Incus looks like incus. Anvil. Anvil is I think what it is after, like, looks like the anvil. Would you hit the nail, na? And the malleus is the hammer, and tip is like the stirrup. Stirrup. You know, I think all these Brits, when they came up with these names, they're all like used to horse ride. Stirrup is what you keep your leg on and climb onto the horse, and the saddle is what they sit on. So a lot of saddle nose. Vomer is basically vomer. There the nose, back of the septum. Okay, so that is there. So this is a part of the nasal septum. So this is fairly straightforward, not much explanation there. You have the malleus. The malleus and the long process of the incus, all of this is there in the epitympanum. The mesotympanum, you have the handle of the malleus, long process of incus, and the stapes. Then you have the round. Okay, guys. Sir, one dialogue in Malayalam. Serial is Tamil. Confused. All right, guys. 20-year-old male patient. Last question, guys. Final question. Hey. 20-year-old male patient presents with unilateral nasal obstruction, recurrent bleeding for 1 year. Transnasal endoscopy, contrast done, and contrast and CT shows mass extending from the posterior quana to the nasopharynx. Very important part being told over here. Posterior quana to the nasopharynx. What is the most likely diagnosis here, guys? Nasopharyngeal angiofibroma है, AC polyp है, cornal ponca bullosa है, या rhinoscleroma है. All of you are correct. It is nasopharyngeal angiofibroma. See, when it is saying, if this was a mass on CT scan showing that it is coming from the nasopharynx, from the lateral side, there can be nasopharyngeal cancer because it comes from the fossa of Rosenmüller, which is right behind the eustachian tube. So if this is the nasopharynx, the eustachian tube opening, there is the tors tuberous. This area is the fossa of Rosenmüller. वहां से आता है nasopharyngeal cancer. Adenoid आता है roof से. Adenoid comes from the roof of the nasopharynx. But this nasopharyngeal angiofibroma comes very close to the sphenopalatine foramen, which is just there in the lateral wall of the nose, near the sphenoid and the palate, palatine wall, perpendicular plate of palate. And there, where the sphenopalatine foramen is there, this originates from there. So this hint that extending from the posterior quana to nasopharynx means from the posterior quana matlab space, quana, space, and going to the nasopharynx. Another hint that's giving us a young male, generally adolescent male, 12 to 15 years get it, but 20-year-old male can also get it. Beefy red appearance, red, fleshy appearance, and very round and globular, you know, not that kind of thing. So that's why now Ankit Pandey, boy recurrent epistaxis, you are right, almost exclusively it is seen in males, but it is possible to see this in females also. And I once got a case where there was a 16-year-old girl who had a unilateral mass and bleeding recurrent epistaxis. I ruled out nasopharyngeal angiofibroma in my presentation, and after that I had the kind of experience that somebody with nosebleed develops, because it is just says almost exclusively or most commonly in males, but it can occur in females. In fact, the extra nasal spread, I mean the spread from the nasal cavity to the maxillary sinus is most common in females, and that's why it can occur in women, in girls also, adolescent girls. All right, so this is nasopharyngeal angiofibroma. As you can see, red, fleshy, leafy looking, smooth, globular. All right, and this over here is the antroconal polyp. Antroconal polyp, AC polyp, which we call. So AC polyp, single polyp from the antrum of the maxillary sinus to the antroconal nasal cavity. So it's coming like this from the antrum to the corona. You can see over here, this is the polyp that is there. And this, normally you see the turbinates should not have air inside it, it's bone. But you see the middle turbinate has this air pocket inside it, and this why this is called as concha bullosa. Concha bullosa. Concha bullosa, alright? It is not the bulla ethmodalis. Bulla basically means anything bulging out or round, like meningitis bullosa. Bulla matlab, bulla ki jana mein kaun hu? Round, big, circular. And the air makes it, the air pocket inside makes the middle turbinate round. Normally it is flat and straight, like as you can see over here. It's a little long like this, but agar ye thoda sa aur round ho jata hai, that is because of air filled inside, and that presses on the osteometal complex, blocks the osteometal complex, drainage of all of these sinuses, and it starts causing a lot of problem. Okay, there's somebody is asking biopsy hyphae wale question mein next best step kya hoga? Yeah, MRI only will be to see the invasion towards the brain and the orbit. ನೂರ ವೆನಮ್ ಕೇಳ್ತಾ ಇದ್ದಾರೆ, ನನಗೆ ಕನ್ನಡ ಬರುತ್ತಾ ಇಲ್ಲ ಅಂತ. ಹೌದಾ? ನಾನು 38 ವರ್ಷ ಆಯಿತು ಬೆಂಗಳೂರಿನಲ್ಲಿ ಬದುಕ್ತಾ ಇದ್ದೀನಿ. ಇಲ್ಲಿ ಕನ್ನಡ ಬರುತ್ತೆ ಅಂತ. ನಾನು ತುಮಕೂರಿನಲ್ಲಿ MBBS ಮಾಡಿದ್ದೆ, ಕನ್ನಡ ಬರುತ್ತೆ ಅಂತ. ಓಕೆ, so where are you from? Okay, I told you I'll answer all of these other ancillary questions in the comment section after my video. Okay, I'm going to be sitting for 1 hour after this video, after this teaching, and I'm going to answer all your questions, I promise. Gaadi pakad ke. Okay, so guys, that brings me to the end of answering all the PYQs. Normally 7 to 13 questions have been asked, but guys, do you see that there is a particular but do you know that, guys, there is a pattern that you saw over here in these questions that we can learn from. And I have given exams numerous times, and especially from ENT. I'll answer some of your clinical questions. From ENT, I have understood one thing. 40% of the questions come from one particular type. Remaining 40% questions come from clinical and emergency, and 20% questions come from anywhere, which will be usually the strange offbeat question. Now, these 40% questions that I am going to ask you, talk to you about, and I'm going to share something with you, is that if you would have noticed even from these questions, abscesses, signs, maneuvers, and procedures are the 4 common things where ENT questions are asked a lot, because they are very hard to remember and recollect, but at the same time they become very simple. All right, पंकज त्रिपाठी की आवाज नहीं आता यार, पंकज त्रिपाठी मेरे को प्रैक्टिस करना. Okay, so but I tried. Okay, Anurag, इसको मैं प्रैक्टिस करूँगा while you practice for your exams. So because I feel 40% of the questions will come from abscesses, signs, maneuvers, and procedures, we have taken the effort with PW and some of the help that I got and created a PDF document which we will share with you, which has all of these 4 segments listed out for very quick revision. Okay, all the abscesses and all the signs, all the procedures, all the maneuvers that are there, common ones, not all of them. If you have missed something, you can add to it, but the common ones that are asked, we have compiled a very small 3-page PDF document for you, which you can quickly read and revise, because इसमें से question आते हैं. You see Bezold's abscess, parotid abscess, subperiosteal abscess of the frontal bone, the number of abscess, Quincy abscess questions कितने आए, signs were asked, or there was the battle sign that was asked, Trotter's method was asked, Heimlich's maneuvers were asked. These are very commonly asked, and you don't have to spend too much time to earn these quick questions. And this is something that only somebody who has given the exam numerous times can understand, क्योंकि ये pattern हमने face किया है. क्या रहे यार, ये पढ़ लेते, ये आता है, फिर बाद में you understand the pattern, and this is a very clear-cut pattern, and it doesn't take much time to read these very simple ones. So you can read this and you can get a good 30-40% of the questions from here, and the remaining, guys, anything that is common and anything that is an emergency should be high priority, and study them in detail. 20% can come from anywhere. You don't know, most other people will also not know, uski chinta mat karo. But what is the most common 80% you should definitely be able to nail. Otherwise, from all of these past questions, you will be able to exclude some of the other questions, you know, through the if the other choices are you know that ye nahi hai, you will be able to get somewhere close. With that, guys, thank you very much. And before I leave, please attend tomorrow's rapid revision series from the very wonderful Dr. Sudha, and he's going to teach you really well and going to see you go through all this so that you can, you know, sail through all your exams. Instruments also, guys, instruments you can read through. Not many questions have typically been asked on instrumentation. Annotated PDF अभी upload होगी ना, अभी team आपको सब share करेगी, and this is the schedule for the remaining sessions, guys. You can watch this and please attend this. After once all of this sprint series is over, we are going to be coming up with more regular classes for you. So all of those saying professional wise kahan se aa raha hai, professional wise kab aa raha hai, something will be announced, and of course we are here to stay. So there's going to be more for you guys. This is just to engage you for your upcoming exams and give you some quick revision tips and pointers. So with that, guys, signing out. If you put your questions or your doubts or anything that you want to ask in the comment section after I end the live, I will be hanging around to answer them. But I had a lot of fun these last 2 hours, and we can do it. The audiometry findings and all of that, guys, I can if you want, for those who want to stay back, I can spend some time answering some audiometry questions, since that is being asked over here. Guys, in audiometry questions, basically what they'll do is they will ask you those tuning forks, which you know, Rene's, Weber's, and absolute bone conduction test, and or the Schwaber's test. In one you close the ear and one you don't. And then there's Gilles and Bing's, which is basically changing the air column pressure. One is by finger, one is by cesial speculum. Bing's is by the finger and Gilles is by this cesial speculum. But what they typically will ask you is various permutation combination of air conduction versus bone conduction versus Rene's positive, negative. So it's very straightforward. There's nothing very complex in it. So I think, you know, if you go through those, and off late I'm not seeing too many questions being asked about it. That's why we didn't include it, and it's not asked in the past questions also. So you can go and spend some time and read those. MD anesthesiology is a good field after MBBS. Of course it is a good field, because as long as there is surgeries and surgeons, there is anesthesiologist to put patient and their relatives to. So very, very important. Okay, tympanometry. Okay, tympanometry, I can tell you, see, in tympanometry what is happening is you are basically checking for middle ear and compliance of the eardrum. So this is the eardrum and then this is the middle ear. You are checking the compliance. Compliance means how flexible is the eardrum. So when in the external auditory canal you put a probe, the probe basically it is an oscillometer which sends you sound, and one is a pressure changer and other one is the battery. Okay, it basically seeing how much sound is reflected back. Most of the sound will go through the middle ear, but some amount of sound will reflect back. Based on that, it is able to gauge whether it is a very compliant eardrum or a not compliant eardrum. So if it is a normal eardrum, you will see an A-type curve like this. You see an A-type curve. That means enough sound went and enough sound which was required came back. But if you see that the curve is not forming because it is just going flat, it is not able to get much of a rebound, then that is a B-type curve which is seen in glue ear. Middle ear has fluid. And if you see that this whole A-type has shifted from the midline towards negative pressure, then that becomes a C-type curve, which is characteristic of eustachian tube obstruction. Okay, so C-type curve is eustachian tube. So A is normal, and AS, which means a stunted S, which could be there in otosclerosis. Okay, and AD is discontinuity, where the A is going up like this, is oscular discontinuity, but it will remain A in the midline. B is glue ear or any middle ear secretions, and C is think battery not letting me write. So C is eustachian tube dysfunction. All right, guys. So leave these questions. I will answer in the comment section or provide you some references. Aramagidine Nuravinam Amele Siktine. Thank you guys very much. Bahut acha laga last 2 hours, and we are going to do more kind of these sessions, and also look forward to engaging with you guys. Take care. Signing out. Jagadish Chaturvedi, born in Bangalore, raised in traffic. Bye bye.